Well, good morning, guys. It's always good to see you. Don't worry, you're not lost. This is my doctor. And remember, earlier on, we promised you a special episode on breast cancer. Well, that is what we'll be doing today. And our mission today is to find out what usually happens when you go for your cancer screening. Because most of the time, we're told, go for your cancer screening or for any other condition. Well, today we'll be focusing on breast cancer. And like we know that October is Breast Cancer Awareness Month. And of course, the fear and stigma that surrounds breast cancer. So today we'll be finding out what usually happens. What are some of the tests that are done? Is it painful? Is it not? I'll be getting myself, a test later on. Stick around till the end of the show to find out what test I will be doing. But we're here at the current hospital and we'll be doing a number of tests just to ascertain or look at what happens when one goes for their screening. My name is Winnie Lubembe. Come with me and let's find out.
Hi Winnie, how are you?
Good.
Welcome.
Thank you.
My name is Dr. Mohammad Ezi. I'm a cancer specialist or what you call oncologist over here.
Okay.
So we've come here to do screening of breast cancer.
Yes.
So before we start with the screening, I just want to say what basically breast cancer is and what you'll expect from the screening.
All right.
And what is the way forward from there onwards. Okay?
Mm-hmm.
So basically, breast cancer is where you get abnormal cells growing in your breast. Okay? In a normal person, these abnormal cells are usually killed by the body itself. But now, when these abnormal cells go out of hand, they start growing and multiplying a lot. So that's the general what cancer is all about. So when you talk about breast cancer, it means that the cells are now growing in the breast. Okay? They start initially in the breast, and if you don't deal with it earlier, it starts to spread. Okay? Initially, it will start to spread to the axilla, most likely, because there are lymph nodes there. Lymph nodes are like the filter organs of the blood.
All right.
Okay? So the nearest lymph nodes to the breast are in the axilla. So they'll spread to the axilla. And if they are not under control there, they'll enter into the blood and then start to spread to the rest of the body. Okay, and that is when people say what stage of breast cancer you are. That means how far the cancer has spread, and so that determines your stage. Okay. So before we start, you should know what are the early signs of breast cancer. Okay. Some people they tend to ignore these signs. The early signs is one, if you say that the shape of your nipple has changed. Okay. Or you have a persistent breast pain. Most ladies who are having periods, they'll have a breast pain during their period. But when this breast pain does not disappear after the periods end, or the pain is persistent, then you need to get yourself checked out. Okay. The other thing is you notice that there's a lump that is not during periods again. The breast becomes a bit lumpy, but then you notice that there's a lump that is not disappearing, or there's a new lump that you have not felt before. Those ones you need to get checked out. Another common earlier sign, if you can find, there is a nipple discharge. Especially if you're not breastfeeding, so you see like something clear, something yellow, bloody, brown, you need to have it checked. Okay. But most of the time, for early breast cancer, a patient may not know that they have breast cancer. The lump, there may be a very small lump that she might not even able to feel it. That is why we need to do screening of breast cancers. Okay. The reason that we do screening is we want to get the breast cancer as early as possible, so that you have a higher chance of recovery and almost a cure. So when I talked about stages, based on where the cancer has spread, let's divide into three major steps. Early breast cancer, this is breast cancer that is just in the breast itself. Then we have the locally advanced breast cancer. This is breast cancer that has now entered into the lymph nodes, the axilla. Okay. And then we have the stage 4 or the metastatic breast cancer. This is whereby the breast cancer has entered the blood and has gone to the lung and the liver and the bones. Okay. But the chances, so if you get the breast cancer early enough, okay, the chances of survival are very good. Okay. For example, if you get generally early breast cancer, okay, like the very early breast cancer, if you do the appropriate treatment, 99% survival rate in 5 years. What does that mean? That if 100 people had that breast cancer and you did the appropriate treatment, 99 of them will still be alive after 5 years. And these are what we call the cancer survivors or the cancer warriors. Okay. If you get the breast cancer at an locally advanced, when it's going to the lymph nodes, and you have appropriate treatment, this is still not something, you're not down the drain. You still have a survival rate of 90%. That means that if the 100 people had that cancer at that locally advanced stage, 90 people will still be alive after 5 years.
All right.
Okay. Then you have the stage for the metastatic. This is not so good because after 5 years, the survival rate is 30% only. That means 70% of people has died because the cancer had spread a lot. Okay. So those are the risks. This is why we need to screen, so that we get breast cancer early enough, so that we give a chance of actually curing the cancer.
Okay. But what about the causes though? Because sometimes people say they don't know what causes it. At times there's some known causes.
Usually there are no causes as such. I mean, you cannot particularly say that this, because he did this, she got breast cancer. For almost all of the cancer. What we have here are risk factors. Risk factors are those that put you at an increased risk of getting breast cancer. Okay. The most important is being a female. That's one of the most important risk factors for getting breast cancer. About 95% plus or even 99% of breast cancer are found in females. Male also tend to get breast cancers, but it's only a very small percentage of them get breast cancer. Then age. As you get older, your chances of getting breast cancer increases. Okay. If you have a prior history of a personal breast problem when you are young, any other breast, it may be, you see, breast cancer is a malignancy, maybe something benign breast disease, that also increases your risk. Or if you had a prior history of breast cancer in you, like say you had a breast cancer in your right breast that was dealt with. So this increases of you getting a breast cancer in your left breast. So that is why even after treatment, we still need to do regular monitoring to catch that breast cancer on the left immediately. It's not necessary that it's going to be metastatic. It will be a different cancer altogether. Okay? If you have a family history of breast cancer, your moms, your grandfathers, your aunts, your cousins, that also puts it increased risk of breast cancer. Okay? Or you have a very strong family history of other cancers. Like in the family, you also have a history of ovarian cancer, a history of prostate cancer in male, a history of pancreatic cancer, or any other history of it. This means that you're getting genes that are predisposing you to get cancer. Okay? And then, so those are basically, the other cause is obesity is a cause. Okay, being fat, being overweight, obese is a cause. And then the other risk factor is using of combined contraceptive pills, especially the ones of estrogen based. Okay? Because estrogen is the one that drives the cancer. Okay? It makes the cancer proliferate. Okay? That is why those people who get their periods very early in life, okay, and they get menopause very late in life, because they've got a very increased duration of estrogen exposure. Because of regular periods, it increases the risk of breast cancer. Then people who have pregnancy and lactation, breastfeeding, but pregnancy early in life, like maybe at 20, 25, thereabout, protect you from getting breast cancer. Because the changes that occur during pregnancy, that there are some breast changes that occur during pregnancy and breast changes that occur during breastfeeding, that makes the cell stable enough, and so it protects you from getting cancer.
So what about like getting a child in your 30s, 35? Are you still at risk?
Okay, getting a child, if it is your first child at 30, 35, it increases your risk. Okay. At that time, pregnancy does not become protective. Pregnancy becomes protective if you get your first child and you carry that pregnancy to term. If you do the full 9 months of pregnancy, around 22-25 years, that bracket of age. So it becomes protective.
Okay.
Yeah.
All right. But what about, because we hear a lot of cases of smoking, drinking. Does that also have like a direct?
Okay. Smoking and drinking, basically, it's just not a risk factor for breast cancer. It's a risk factor for all other cancers. Also, other cancers, also for other diseases. So it also increases your risk for other cancers, but smoking also increases your risk for breast cancer. But the risk is not so much, but it still increases your risk of getting smoking, and alcohol also increases the risk for breast cancer, and also increases the risk of other cancers.
Okay. All right.
Yeah.
So, okay, fine. So here we are today.
So, okay. So now you are here. So I wanted to ask you, have you come just because you heard in the radio about go for screening breast cancer, or you felt a lump? That is why you came over here.
No lump. So it's just
Because the reason being, when you've if you have no symptoms and you come to say I want to screen for mammography, the technique is we still do a mammography. But the term is different. We usually call something a screening mammography. And if you have felt a lump and then you come for mammography, we call it a diagnostic mammography. The difference is in the dose of radiation they give, and the technique is a bit different. It's the same machine, but the technique is a bit different. Okay? So basically, if you come for mammography, for screening, the first thing you need to be examined by the doctor. He has to do a breast examination to be sure that clinically he himself is not feeling any lumps, any bumps, any masses, any nipple skin changes, or any nipple discharge or something. That's the first thing. Okay? If the doctor does not feel the breast exam is normal, there's no lumps that have been felt, and so they can have a good history about it. So now the mammography also depends on the age of the patient and your risk factor profile. Okay. For example, if you're coming if you have a normal average person, with no added risk factors, okay, we usually advise for mammography after the age of around 35 to 40 years. Okay. If you want to screen for breast cancer below the age of 35 years or 30 years, we tell you to do a breast ultrasound. Okay. The reason being, after the age of 35-40, your breast becomes a bit dense. So it's better, the lesions are a bit picked up better by the mammogram. The younger, greater than 35, your breast loses a bit of that fibrousness, dense. So the lesions are easily able to be picked up by mammography. But the younger breasts, because they are dense and they have too much fibrous tissue, less of adipose tissue, because that's what keeps the breast firm in younger ladies, mammography may miss a lesion. Okay. Now the timing is usually, if you're coming for screening 40 years, for 35 to 40 years, you do a mammography every year. Every year to 2 years, minimum at least every 2 years. But if you are a patient who have a high risk, a very strong family history of breast cancer, even ovarian cancer, or any other cancers, so you look at your relative, and the youngest relative to get that breast cancer was at what age? Say for example, your mom got her breast cancer when she was 40 years old. Okay? So you will start your screening at 30 years old, 10 years below the youngest. So if your family member got your breast cancer, say like around the age of 25 years, or 35 years, so you'll start your screening around the age of 25 years.
Okay.
And because of depending on how your risk factor, your risk of getting breast cancer, it's not necessarily that you'll do mammography. So with some of these patients also, we tell them to send for MRI also, of the breast, so you can pick up the very small lesions that could have been missed by mammography.
Just take you back a little bit. Why the 10-year difference in terms of, let's say, the family history? For instance, like you said, if, let's say, someone in the family, for instance, the mother got breast cancer at 35, you start this other person at 25. Why the 10-year?
Because you're expecting the changes to occur a bit earlier, and you want to catch the breast cancer earlier. Because you know that this family is starting getting cancers at around 25, 35. I want to screen you. Screening means that you do not have any symptoms. So there's no point of screening you 2 years, and I know at 35 you might have a high chance of getting that cancer at breast. So we want to screen you early. it's not like a hard and fast 10-year stuff, but
You
it's
have to-
advised
okay.
that those people who had higher risk should start their screening earlier than the normal population.
Okay. All right. And what about self-examination? Can you do that, let's say, before you go for screening, or is that also part of screening?
Self-examination, will not catch. Self-examination. First, when you're doing a self-examination, you should time it with your periods. If you're saying you want to do self-examination before your period, so your subsequent self-examination will also be before your period. Because there are changes that occur during your menstruation that might make you a bit confused, like is this normal or is this abnormal? Self-examination will not pick up very small ones, those lesions that you can't feel, like less than 1 centimeter. Those ones are picked up by mammography. But in the current scenario in Kenya, how it is nationally, we are getting too many patients who have got advanced breast cancer. So what self-examination will do, you'll pick up your mass earlier.
All right.
So it will sort of you'll probably get your cancer earlier. Like if you have just been you feel like maybe you can feel like a 2 centimeter mass, you'll be able to about 2 centimeter mass. So I've gotten your cancer a bit earlier. That is how self-breast examination assists.
Okay. And how often should one do it then?
Breast examination?
Yes.
At
Do you
least,
do it like once a year?
No, self-breast examination once a year would not make much a difference.
All right.
At least do it regularly once a month during your period time, so you can know. Or even maybe once in 2 weeks. But most people advise at least doing regularly, at least during your periods. So you can take your periods as a reminder that now I have to do the self-breast examination. Just standing across in front of a mirror and examining for any irregularities, any bumpiness or lumpiness. And then you try to feel whether that lump was felt last time or was not felt last time.
All right. So are there anything that, let's say, any preparation that one has to do before they come for, let's say, their screening?
There is no preparation one has to do. I mean, there's nothing like you should not eat your breakfast or I don't know. You should, there are no special preparations. Just need to have comfortable clothing and easy to remove and wear tops. Because you got to remove your tops and just basically it. And it's not even a very long procedure. Maximum will take like 10 to 15 minutes and you are done.
All right. So what am I going to do today?
So first we'll examine you, I'll examine your breast and exactly what's happening. And if your breasts are normal, then I'll write a request for you to go to the radiography department. And if I feel no lumps, I'll do a screening mammography. And the screen will go there. The doctor will also explain what is supposed to be done. But basically what happens, your breast will be kept against 2 plates, and your breast will be pressed. And they'll take like an X-ray, just like an X-ray machine. Don't get worried, it's not painful. It's not painful.
Oh, it sounds painful though.
You find it a bit uncomfortable.
All right, feel like some sort of
soreness. Pressure, like your breast is being pressed. But then when it's done, and then you'll just be told to wait outside while the radiographer processes your films and writes a report for you.
So I'm done with my consultation with the doctor and I've been sent to the imaging unit. As you can see, there are several tests that one can do in the imaging unit, from MRI, X-ray, CT scan, ultrasound, and mammography. But most of the time during breast cancer, one can decide to do either MRI, they can do an ultrasound, and mammography. You do not want to go anywhere, because when we come back, we will show you what happens when one goes for their ultrasound, for the mammogram, and MRI. Stay with us.
Hi, good afternoon.
Afternoon, how are you?
I'm good, Winnie.
Set to bring back.
Yeah, you are due for a breast ultrasound?
Yes.
Just come in, have a seat inside here. We register, then we take you in.
All right. Thank you.
You're welcome.
Welcome to ultrasound room today. I can see the doctor has requested that you do a breast ultrasound. For the ultrasound, you can do any part of your body, but the doctor today wants us to do the breast ultrasound as per your age. Before we proceed, I will explain to you what is done in the room. Yeah, you're going to change to our hospital gown. I'll give you the green gown to dress up with the open side in front, so that we don't dirtify your clothing. Then after that, I'll apply some cold gel on your breast as I check through your breast to see if there is anything unusual. Yeah, after we are done with the procedure, you'll give me like approximately 30 minutes. I write you the findings, then you can go back to be reviewed by your doctor. Any question as far as?
I just wanted to know, so then how it works, like what does then the ultrasound do in terms of what is it supposed to pick, what is it not supposed to pick, and especially during the procedure?
Wow. During this screening month, we are doing ultrasound for 40 years and below, because at that time your breasts are a bit dense. So for the ultrasound, it uses sound waves to generate the images. So you'll be able to pick any cyst, we call them cyst, fluid region, or a mass, anything unusual, because you're checking on the breast tissues how they are. If you find anything unusual, we just recommend you write down our findings, then your doctor will advise you on the way forward. Yeah,
Okay.
for 40 years and above, mostly we do mammogram.
Okay, all right, and of course we'll do the mammogram later. All
Yeah.
right, so this is the ultrasound
Yeah.
machine. Just take us through.
This is the ultrasound machine. So I'll just key in the details for my patient. In the hospital, we usually have a identification number, that's what we call the MRN. So I key in my details depending on my patient who is on the wrist. Now I can see my patient as those numbers. Then I write down the name of my patient. I have to write all the 3 names so that I don't have any confusion of names, because some people do have similar names. So I really have to counter check, and after I write down, I ask the patient to counter check, is this your name, so that I may not be dealing with the wrong patient. Then still, because they were seen previously by their doctors, they'll have to tell me their height, their weight. I write the referring doctor, why are we doing the examination? Is it an observation that was done and the doctor recommended we do a scan after several months? Is it the first time that you're doing the scan? So I indicate it there.
Okay.
For the ultrasound, still you can do for either male or female. So I indicate who am I attending to, who is performing the ultrasound. For the ultrasound here, the sonographers and the radiologists do the ultrasound. They have more knowledge on how to carry out the studies. Then still I have to write down the date of birth. So I ensure I fill my first page. For this, I'll write a temporary name so that you can proceed down. Where I can say my name was Wangoi Mary. Then I just omit others for now. Then I'll proceed on to OK. Then now it opens for me a page now where I can start off my study. We have different props that we carry out the studies with, depending on what we are doing. But for this one, we are using a linear probe to do the small part. For the breast, we call it a small part, just like the thyroid. The scrotum, we call it a small part. So I'll come to my preset. It has different things. I'll come to small part and then pick on my breast. As per that, now I'm okay with my settings in my machine. Now I can start carrying out the procedure to my client. Then for my probe, I usually take it, then apply some cold gel. The gel helps in the lubrication so that I'm not having friction on the skin of the patient. I apply some gel on my probe. Sorry. Then I'm now ready to carry out the scan on my patient. Applying the gel on the breast of the patient, I go systematically as I check through the breast tissues.
Okay.
Yeah.
All right. Okay. And are there any specific preparations that one has to do before coming for an ultrasound? And then are there some people who are not sort of allowed to conduct ultrasounds, and especially for breast?
Well, for the breast ultrasound, we don't have any preparation. It can be a walk-in and then we do the examination for you. No really much preparation that you really have to do, providing that you're meeting our criteria, 40 years and below, depending on what the doctor wants us to check. Then for the ultrasound, mostly we encourage the female to do to the female client, but in case the sonographer on duty is a male, then we ask a chaperone, a female representative, to be in the room for confidence of the patient and the privacy of the patient. Yeah, so that at least the patient feels comfortable as we handle them.
Okay, all right. Now, for purposes of maintaining PG and as well as privacy, we'll not be showing you the actual procedure on me, but of course, we'll be having someone else to come in so that you can see clearly what happens during an ultrasound session. But of course, later on, I'll be sharing my experience with you guys. So you want to stick around for that. But for now, we'll get someone to just show us the actual process of what exactly happens when someone comes in for their ultrasound session.
Okay. Welcome now to the actual breast ultrasound scan. Our patient has already changed to the hospital gown with the open side in front of the hospital gown. Now I'll change his positioning, how he is at the moment. Is a position that I need him to be in as I carry out the standing. Okay. Now you're going to start with the right side. You're going to raise your arm up once. Then I'm going to expose you up forward. We expose our patient. We're starting with the right breast. So now I'm going to apply some cold gel on your body solely for that. Going to apply some cold gel. So now I'll check through the breast. I'll scan through the breast round, checking on the breast tissues if there's anything unusual on the breast. So for the breast ultrasound, it can be done on any person. It can be either a male or a female. So no one should be worried about it. So I've gone systematically through the breast. You can see the breast tissues are okay on my screen. So after I've just checked systematically, now because the doctor who requisitioned for the exam is not in the room, I have to acquire some images that the doctor can see. So I have acquired my first image. I have to label which part was it. This is just the right breast. Right. Then it was just the upper. Sorry, it was the lower inner quadrant. I just label that. Then I acquire my image so that the doctor who requested for it will be able to see the images. Then I just go through again, just check on the inner side. Then I acquire that. Still I will label it. This is my right breast still. So this is upper inner quadrant. I can acquire that. I just go systematically through the breast. Sorry. Do the same again. I acquire. This is the right breast. This now was lower outer quadrant. I acquire. Then the last one, it will be that again. Right breast is upper outer quadrant. I acquire. Then still on the breast, we cannot miss out to check on the axillary area because there's some knots that do grow around the region. So we have to check through the axillary point to ensure there is nothing. Check for any lymph nodes. So check through. That's my axillary. So this is the right breast. Axilla. Still, you check on the nipple area, especially for the breastfeeding mothers, around the nipple area, around the areola area, the dark region of the breast, areola region, the darts could be dilated, so you have to check through the area there. So check through the areola area next to the nipple to ensure that the darts, the mammary darts, are not dilated. That's okay. Then I take my image. That's now documents around the nipple area. It was still on the right breast. With that, I'm done now with the right breast. So now I'll turn over to the left. Okay. You can lower your arm, raise the other arm up once, then still going to expose on the breast. Sorry, some cold gel again. Do the same thing again. I'll go systematically through the breast. Still, I'll acquire images again for the purposes of documentation for the patient. The doctor will be able to see the images because the doctor was not in while the study was being carried out. Start with the left breast. Choose lower outer quadrant. Okay. Upper outer. Okay. Are you comfortable?
Yes, I am.
Okay. It's good to reassure the patient. Sometimes they might be uncomfortable and you're not aware. Inner quadrant. Check around the nipple area again. Okay, some cold gel again around your axillary, around your armpit. Okay. That's the axilla. You check that there are no lymph nodes that are there. Okay. Okay. With that, we are done with the procedure. Now I'll just ask my patient to sit. You can sit. Then I give him or her a sheet to dry off the gel. Then I'll give her some 3 minutes in the room so that he can change.
All right, so I have changed, as you can see, in this fancy robe, ready to go for my ultrasound. You're not coming with me, but I'll share with you the results in just a while. So do not go anywhere. I'll see you in just a bit.
Our mammogram machine, there is no pain when we are doing this procedure. Purposely, we do it for screening. When we do this, it has advantages of ultrasound because it can pick even small lesion that ultrasound can miss. The purpose for this, since we are using for screening, we normally encourage clients to be coming yearly for good diagnosis. This is the part we are putting press, and this is the paddle. When we put press, like now, if this was pressed, we put it here, then we compress gently, depending on how sensitive your breast is. When I'm compressing, I'll be asking, how discomfort is it? When you feel much uncomfortable, I just leave it and do the procedure. Then we turn, there are like different views. Like this one is the first one, we call it craniocaudal. Then there are lateral, medial, oblique. We turn now this part around 45 degrees. The whole procedure depending on the cooperation of the patient, because sometimes the patient is feeling uncomfortable, you have to explain again. It will take, within 30 minutes we are done. Then the report will be within 24 hours. It can be 5 hours, 3 hours, but we normally advise within 24 hours the report will be out. Clients normally ask questions and we encourage them to ask more, at least to get being equipped by the knowledge we have for this procedure. In preparation, like when you are 1 week to menses, you find your breasts are dense, they are maybe a bit sensitive, so we normally say at least after 1 week since your menses are completed, so that you don't feel much pain, because when we are compressing, it's a discomfort, and again it has advantages. When you compress, you find you are using less radiations. Again, you find detailed images. It helps despite being discomfortable. And again, like deodorants or the lotions, I said, sometimes you find there confusion of that calcium deposits. You find there are sparks which will give wrong diagnosis. So you just like showering yourself, don't put anything on your breast, even on your axilla region, because we include when we are doing examination. In this procedure, there is an false negative and there is false positive results. Sometimes when it's false positive, we can do ultrasound correlation, or we can do biopsy to rule out, because there might be some factors which made to that false positive. Sometimes again you find, because this one we use for screening, you might find it is missing some, because not all the cancers are detected. So when there is a problem like images, dense images, we ask patients to be done ultrasound correlation. If ultrasound will show something which is not much clear that we can say this is cancerous or not, we ask for biopsy or even a tissue diagnosis to rule out cancer. Okay, since the procedure is using radiations, and again radiations can cause cancer, we normally ask clients before the procedure is done, they give us more information on the personal or family history of cancer. And again, if they have ever done, if it's a follow-up, they get back images to radiologists, the previous, for comparison.
All right, so there we have it, a very beautiful day spent right here at the current hospital, where of course we just wanted to understand what usually happens when one goes for screening, especially for breast cancer, October being Breast Cancer Awareness Month. And as you can see, the process is pretty much smooth. It's not painful at all. So all the ladies out there, if you are watching us right now, be sure to go and get yourself checked or screened for breast cancer. Remember, the earlier you know, the better. And that is where we wrap up My Doctor today. Thank you so much for staying with us. We'll see you on another episode of My Doctor. But for now, it's a goodbye from us. My name is Winnie Lubambe. Have yourselves a lovely day ahead.